Welcome to our CNO Corner Unlocking Innovation webinar series. Thank you for joining us for this conversation featuring Melissa Alvillar, Chief Nursing Officer at Memorial Health System in Southwest Oklahoma, in discussion with Outset Medical's Chief Nursing Officer, Brittni McGill. Melissa will share her team's experience bringing acute dialysis in-house with Tableau. The discussion will be followed by a live Q&A, so please feel free to submit your questions in the chat at the bottom of your screen at any time. Brittni, over to you.
Thank you so much, Ariel. Good afternoon, Melissa, and thank you so much for taking time out of your super busy day to help professionals across the country realize that they too can be as bold and innovative as a nursing leader like you are. So if you'll just start with a little bit about your health system and your background.
Yeah, thank you. Thanks, Brittni, for having me. My name is Melissa Alvillar. I'm the Chief Nursing Officer here at Memorial Health of Southwest Oklahoma. We're a single hospital, and as of December, we acquired another hospital locally, and so we now run a bed count of about 400 beds, and that is to include a behavioral health center, a nursing home, home health and hospice, and very recently in this last year, a dialysis or in-house dialysis program.
Perfect. Thank you. So you and I shared the same organic or statewide third party, and Melissa made the bold decision to insource using the Tableau technology. Melissa and I have the same background in that we did not have any direct dialysis experience. We had to teach ourselves and guide our teams. And so, Melissa, if you could share a little bit about what your experience was with that outsourced third party and really what made you make the decision to make this change.
So there were several things. I would say the biggest things were the quality of care for our patients, number one, and the care that they would receive in the dialysis unit. I mean, giving some examples, like if the patient was maybe dirty while they were in the unit, they would go back to the unit, to their home unit, still dirty, just some kind of things like that. There were some struggles with staffing for the company, and so there was a lot of turnover within their nurses, and the compliance piece was a big issue for me, because there was so much turnover trying to maintain their records for Joint Commission, and their compliance was a struggle. And so those were some two big key factors for us. And then the cost of the program. At the end of the day, it's very costly to the organization. And so those were the three big pushers for me to try to look for another option.
So not only did you insource your operation, but you chose a very patient-centric technology, and that is the Tableau device.
Yes.
Do you mind sharing your thought process or decision in device selection and maybe a little bit about the connection to your personal why?
Sure, yeah. So in looking for other solutions, we had previously had the standard dialysis machines that were actually ours. We owned them, and they were utilized by the dialysis company. And so as we were looking, though, at the cost of that and then running those machines, and we had to get new ones, we were due for new ones. We actually had Dr. Rubin reach out just by chance, to reach out about Tableau. And this was a 3 year ago conversation that we had. And my ICU director at the time and I went to a hospital about 2.5 hours from here, and to go look at the system. And I immediately fell in love with the system. First of all, the facility that we went to, the majority of actually their staff at the time were agency dialysis nurses. And they had a couple in-house full-time, and the rest were agency. And even the agency nurses talked about how easy it was for them to use these machines, never have using Tableau before. And so as they walked us through how to hook it up and how easy it was and how user-friendly it was. I started thinking about, the history. They were kind of giving us the history a little bit, and we had learned a little bit that it had been originally developed for in-home dialysis. And my dad, who donated a kidney to my uncle many years ago, probably, oh my gosh, 25. My dad and my uncle have since passed away. But my dad, after donating a kidney, went into renal failure a couple years later. And I took him to dialysis 3 times a week, dropped him off. And I just wish that I had this Tableau system for my dad, because it was so easy to use. Like, even if you are not a nurse, you can use this machine. And which for us, so as a nurse, it makes it even easier. But the Tableau system itself was a win for me at the time. Immediately, like, I thought, oh my gosh, how do we go forward with this? And then from the dialysis patient and family perspective, the nurses talked about how much easier it was on the patient during dialysis versus the bigger, most common machines. And I thought, oh, this would have just been heavenly to have for my dad.
So you touched on how this device was originally made for the home because it's so easy. The same device can be used in every level of care. And I know that in your health system, when you insourced, you not only did the dialysis unit, you also did the ICU. So you're
Correct.
taking care of the sickest of the sick patients on a single machine. Could you talk a little bit about the efficiencies gained by having both acuities and levels of care?
Yes. So when we started, actually, as we went down this path, our original thought was like, okay, well, we can dialyze our patients in ICU, and this Tableau machine was going to give us the opportunity to do that. But the third party company wasn't interested in using the machines, and so what we decided was that we would just do it ourselves in ICU. We would go down the path of education for our ICU nurses. They were very excited to do that. And it has done wonders for our ICU patients, because now we can do PERT and SLED in the ICU and these patients that need it. It's been a big fan of our physicians to be able to run these long treatments at a slower pace for the patients. But then we also take care of the patients, the daily patients, the ones that come in and are on Monday, Wednesday, Friday chair time, and they're in the hospital, and they also get dialysis on the Tableau machine. So we are able to take care of our sickest of sick patients in critical care, that are maybe not only there just because they're a routine dialysis patient. Now they've just had acute kidney injury and are now a new dialysis, and the machine serves a great purpose. And so you have to debunk the at-home machine theory on what sometimes you'll hear, because it takes care of our patients greatly.
Thank you for sharing that. This webinar is a part of the AONL Innovator in Action series, and you really innovated along with your team how you transitioned. Do you mind sharing with the audience? Because I think a lot of time nursing leaders get overwhelmed at the thought that there are a lot of steps and that this may be complicated. But what I've seen across the country is lots of nursing leaders really personalize it and individualize it to their specific instances, which is exactly what you did. So I think if you'll just share how you worked through that, be helpful.
Sure, yeah. So I was in a state where we were making a big financial commitment, because there is the financial commitment up front, right, of purchasing the machines. And we are not considered rural, but the majority of the patient population that we serve is outside of us is all rural. And so resources are scarce. And so we were making this decision to go ahead and move forward with Tableau. And so my mindset was, this cannot fail. This cannot fail. And the best way for me to get in there and figure out how to not let it fail was to do it. And so what I will say is first and foremost, what is the most key is to have a team around you that is going to support the mission. So my ICU director, who also was overseeing dialysis at the time, him and then our ICU night supervisor, who used to be a dialysis nurse, they were on board and they wanted to see this happen. And so the three of us really took the bull by the horns and said, okay, we are going to make this happen. So first and foremost, you got to have a team around you that's going to help support that push. But what we did was I looked at some of our struggles. We did like a little bit of a risk assessment on our situation. And what I could see was the biggest barrier to success was going to be nurse turnover. And I thought, why do they have nurse turnover now? What are the problems? And what I could see was it was a 24-hour service. Patients come in, and whether or not they're really emergent, they could be done at 2 a.m. And so the nurses, which were a select few of them, were just running ragged. They were running ragged, coming in all hours of the night and then expecting to be back here the next day. And so my thought was, if we are doing dialysis in ICU, if that's our start, and we train our nurses in dialysis, which I will say our ICU nurses were excited to learn dialysis. They were excited about it. I had probably 2 out of my whole group. We have a 26-bed ICU, and there were only 2 of them that did not want to partake. And they were also on the verge of retirement. So I got that. But if we started in ICU, if a patient's really critical, they should meet ICU admission status. So do I have to run this unit 24/7? And so I came up with no, I don't. So what we did was we said, we are going to do critical care admission dialysis. If they require dialysis emergently, they should meet that criteria for critical care. We will admit them to critical care and do their dialysis. If they don't, we are going to go ahead and we're going to work an 8 to 8 schedule. And we went ahead and extended hours outside of what even the normal business day hours were. And we're going to work 8 to 8, Monday through Saturday. And that we don't do dialysis on routine patients on Sunday. We don't do dialysis outside of 8 o'clock. I mean, if they're actively going, then the staff knows upon hire that they're going to finish that treatment, but they're not going to start any new treatments. And we did have to build into the policy that, there's most dialysis treatments that we're doing are 3 to 4 hours. And so, we kind of have a cutoff of no new admissions to the unit after 5 o'clock. And we also, with that, had to make the decision that we weren't going to do PD. We don't have a lot of PD patients in our area that get admitted. I looked back at that history to make sure that we weren't going to cause a problem. And honestly, we've been free on our own since July. And I just had my first PD patient like this last weekend that had come in that we did have to ship. But that's one patient, and I knew that was going to be a risk. So outside of that, the system, the process has gone well.
So you talked about the upfront capital costs of the equipment. There are also some salary expenses, but like any business professional, you did the business plan and you had an ROI. And can you, talk about the financial, operational, and then like clinical benefits of insourcing with the technology, and then maybe share some of the results you've seen so far?
Yeah, so the upfront cost was a little bit intimidating, but we knew we were going to have to purchase new dialysis machines regardless because of our other ones that were going end of life. With that, the cost of the supplies for the Tableau system is so much less than a standard dialysis setup. I mean, I think it runs us around $75 for a whole setup. Which is amazing. And then you're cutting out the cost of what they're charging you. So our cost in our contract had recently gone up $100 per treatment. And so we were pushing anywhere from $400 to $500 a treatment that we were paying. And we do about 2,000 treatments a year in our facility. And so even with the cost of hiring a couple of nurses, it was still going to be cheaper for us to run this program in-house at the end of the day than it was to go ahead and to maintain what we were doing. And I will tell you that for this year, it's looking that we're going to save $72,000 in the first year, with a projected amount of potentially $1 million in the next couple of years per year that we'll be saving on our dialysis cost. And so to touch on the clinical pieces, we had a run of CLABSI concerns. And so we've been doing all these things as an organization to look at our central lines and putting how they're being put in and changing the dressings. And I feel like we have tried all of the things. And one of the things that I noticed when we were in the dialysis unit, as we were in the process of taking over, was the access of the lines and the fistulas and how that was going. It caused concern. It caused me some concern. And so one of the things that we started looking at after we took over was our central line infection rates. And like I said, July, we had fully taken over, and we have not, knock on wood, have had one central line infection since we have taken over dialysis.
Congratulations. I mean, that's
Thank you. Yeah. And as nurse leaders, like I know that there's this initial cost here, and the win to the patient, number one, is the win to the patient. Yes. But that's going to impact your CMS star rating. That's going to impact your leapfrog. I mean, it just goes on and on of how that win is going to impact you down the road.
Mm-hmm. I was thinking about what you shared earlier about, vulnerable patients and how they were not properly cared for. And it's just gut-wrenching to think that they weren't receiving the quality care with dignity and respect that they should. And now that they are through the insourcing process, look at all the other benefits. I mean, I'm sure your patient satisfaction rate is up as well.
Yes. So our patient satisfaction rate and our staff nurse satisfaction. So I had shared with Brittni previously that I was upstairs one day on the floor, and one of my charge nurses came up to me and said, "Melissa, I just want you to know that taking dialysis in-house was the best thing you could have done for our patients." And so, I mean, that was my validation, right? Like, okay, we did the right thing, because they see the impact to the patient care. And I mean, it was things, just calling report, right? Calling and receiving report, things that going back to the compliance piece of like, this is what we need to do, but you have somebody else and you're trying to hold that team accountable. And the team that we have in place now, like, they know that this is what we do here. You're going to call and receive and give report. And even now, like the team in dialysis, when the patient comes down for dialysis and they hook them up, they go through and they've kind of been tasked with like checking all the other dressings, check the peripheral line, make sure that dressing is good. If this line needs to be changed, but it's kind of, just go ahead and change it. And they've been champions with that. And I love that.
Yeah. That's huge. When you empower your team to take proper care of patients, it just comes around full circle. Yeah. Initially you had talked about you can't let this fail and this has to be successful. I mean, I think it's critical amongst our professional peers to just shed some light on what that pressure looks like and what it feels like to frankly be scared to do something this massive. And, how when your nurse said this was the best thing we could have done, that was your validation.
It was stressful, because like I said, resources are scarce. I was trying to figure out, if this doesn't work, if I don't go back to this third party company, who am I really going to go to? Because as far as I knew in our area, there weren't really any other companies. If we went further north, there would be. but how am I going to prevent this from, how am I going to make this successful? And there was a lot of pressure and sleepless nights that went along with it. And I think just building out the program itself, like I said, like, how is it going to look? What are we going to do? How am I going to deal with the physician pushback? Right? Because that's a real thing. It's a real thing. Like I can't argue with their, what they think that they need for their patients. And was this not doing dialysis on Sunday or after hours, was it really going to be a problem for me? And, how was I going to deal with that? And how was I going to support my team through that? And I think that once they realized that they weren't going to scare us out of the transition, that it was kind of like, okay, this is what they're doing. This is what they're doing, and we're going to have to get on board. And there was some pushback. But I mean, what I loved about Tableau is that they have physician modules. There is physician training specifically to help the physician, number one, understand how the machine works. And it really does work. Just like your big, massive box machine, it works. It's going to work on your patients. And so there is a lot of physician support and education along with your staff support and education that they give them. And I can get in there and see, oh, Dr. McGill hasn't done her education yet. And so then I can message her and say, hey, I was just checking in, or when they had questions, I would say, oh, you know what? I think that was in the education on the Tableau Hub. Have you finished that yet? And so that was, kind of gives you a little bit of a leg to stand on because the answers are there. They're there for you.
Do you want to touch on when one of those concerns was around clearance? How did you guys creatively help them through that concern that caused some of that nephrologist pushback?
So there are a couple of things. So I will say that the support. So we did there's a transition program that Tableau Outset has. And we went ahead and made the decision because myself and Michael were not ICU nurses by trade. And so we had to do the training, right? We did the training and the orientation. My supervisor, Cheryl, she was very supportive in education with us because she did have dialysis experience, but she was on nights and she was helping manage the ICU, right? And so that was her mission, was to make the ICU successful, do all the things that they need for training and help and education. But we chose to employ Kelly through the Bridge program through Outset. She is a trained dialysis nurse and trained on the Tableau system. So we first did the vascular access program, which I personally loved because I'm sure myself and anybody else that takes care of this demographic of patients knows the damage that can be done to their fistulas. And so understanding the fistulas, how they work, how to access them, what to do if you run into a problem with them. So we did 2 days of vascular access training through Outset, which they only take 4 people at a time, which I also loved that because it was a small group. You do these accessing on the arms that they provide, which are really great because some of them are like real life in the way that you can't find them. You can't find the fistula. It doesn't go exactly the way the textbook says it should go. So that was really great. But then also Kelly, with the Bridge program, she was here with us Monday through Friday. She was here Monday through Friday with us. And she worked side by side with Michael and I, and she provided our orientation. We started, like I said, we started in ICU, and then we took over. We have a 4-bed dialysis unit. And so Mike and I took 2 patients, and then the third party had 2 patients, and we transitioned for about 6 weeks that way. And so Michael and I spent 6 weeks basically orienting with Kelly, and we became dialysis nurses. And then Kelly took a break because we were in between contracts, because then I decided I wanted to re-up my contract with her one more time. But what was great was Kelly was really great about helping us also navigate some of the physician concerns, because some of them were very technical, their questions. And because Kelly had the knowledge and the background of not only of being a dialysis nurse, but also running the Tableau system, I mean, she can talk to you about how the machine worked and how, oh, well, you think it doesn't do that, but here's really what it does. And so she was really an important part of our transition. If we, especially being in a place that we didn't have a lot of dialysis support, like we didn't have a lot of nurses in house that had been previous dialysis nurses. So for us, it was important that we had that, because we weren't only just learning the machine, we were also learning to be dialysis nurses, the side effects, what to do when these patients start cramping or when they start vomiting, and which I will say on Tableau, we rarely dealt with unless it was a new start. We rarely dealt with a lot of side effects, and patients will come in and say, oh, I can't run that fast, or I can't run at that, or I can't run that long. And we would say, hey, well, just give it a chance. You know, this is a new machine. It's brand new as far as like to our facility. And I said, just give it a try. And they would do great. They would run, they'd fall asleep, they'd run their whole system through, and they would be great. And then so the patient satisfaction was there, because they feel like they didn't hurt, they got their full dialysis, and then they were able to go back and they felt great.
Yep, that's awesome. I want to touch on a little bit about, you train ICU nurses
Mm-hmm.
instead of going the other direction and hiring experienced dialysis nurses. So for those listening, talk about that decision and how Tableau as a device assisted in making that decision.
Um, the device itself is very, very user friendly. I mean, it walks you step by step. Open the door. You're going to open the package, hang the package, put the cartridge in here, press here, put the cartridge in down here, press here. I mean, it is very step by step. And so even if you were off for a week and came back, you're not going to forget what to do, because the device is very, very simple to use. And number one, the nurses wanted this, they wanted to do it. But number two, when those that maybe were hesitant and a little scared initially, we required everybody to go through the training, like on the machine, how to use the machine, what the alarms are like. Because if somebody's at lunch, you need to be able to, if you hear an alarm or whatever. And so everybody went through the training. And so those that maybe were a little bit more hesitant from go, once they realized how simple it was to use, the fear factor went away. Mm-hmm. And so the training the ICU nurses, I mean, like I said, initially that was going to be my phased approach, was just to go ICU for a while and then kind of see how it went. Mm-hmm. Right. But then once it was going so well in ICU, it made a very quick decision for me to say, we can do this.
Yeah.
We can do this. Yep. And so we had some of our ICU nurses, once we went full into our dialysis unit, that were like, can I come work dialysis? Can I come work dialysis? So some of them initially, I mean, they were really helping us out, because, Michael and I were working every single day from 8 to 8, and when they wanted to start coming over and helping, it was great, because they would work their 3 shifts in ICU and they'd pick up another shift in dialysis, and we had just enough of them initially that it worked out. So it was a good transition, and you're going to have, I think, some nurses that aren't going to be down for that initially, because they're afraid.
Yeah. I mean, the beauty of taking an ICU nurse is that they already have all that critical care training. They can manage hemodynamics. They can run a code, provide blood transfusions. the machine's the easy part.
Yes.
Right, they had the patient care down. We had a question in the chat about nurse training. And
Mhm.
so for Julie that asked this, there are online modules that go over how to care for the dialysis patient. Then there's online training about the device. Then that's followed up with in-person device training. And then you heard Melissa talk about there's a bridge offering, there's a Tableau coordinator offering, which we highly recommend, which is basically our version of a super user. And then there's the vascular access offering, along with another entire a la carte menu to help support you and your success.
Yeah, and every user has access to Tableau Hub, and
Yeah.
Tableau Hub is where all of the education is. And so even if there's something that comes up and you need to like look at it for re-education or something, you can just log into your Tableau Hub and watch. There's some helpful videos, there's some troubleshooting videos in there. And so all of initially the four of us that went through the vascular access training, I mean, we did all of the Tableau Hub, and then as our nurses started onboarding through the ICU, they all had to go through and do their Tableau Hub, and Michael and I could get in there and see again, Brittni, you haven't finished your modules yet, but the majority of them, and the modules are easy. They're not super time consuming. They're not just like overloaded with information and in a way that people can't understand. So I felt like it was really user friendly.
Agreed. Just because I've done it as well. So as we wrap this up, what do you want people to take away from this?
I want people to take away that you can do it, because this was, I mean, and I would be happy to give you any advice that you need, but you can do it. And it is daunting because we are so reliant on these third-party companies. And there are some dynamics sometimes within these contracts and within these companies that can cause more anxiety and stress than it probably needs to be, but it's real and it's there. And I think the big takeaway is you can do it, and it is better. It's better.
Yeah. And I mean, all the upfront work was worth it because
All the
now
upfront work.
it's running itself.
It's running itself, and I've got a great team in there. My care is fantastic. The patients are happy. The doctor pushback has gone away. And so it's been a fantastic transition. But I mean, trust me when I say, and Brittni knows too, because she did it too, like it is scary up front. It is, but you can do it, and it is doable. It is doable.
Yeah. I would just, add to that, how many opportunities do you as a nursing leader get the ability to make such a tremendous impact on the patient, on the teams that you lead, and have clinical, operational, and financial gains?
Yes.
It's pretty rare. And so, looking back at the process of implementing and insourcing operation and really starting an entire dialysis service line, it's I was grateful for the opportunity because
Yes.
they're rare.
Yeah,
Yeah.
absolutely.
Okay, Melissa. Well, we've answered all the questions in the chat. Thank you again for the time,
Thank
and
you.
we hope continued success for you.
Yeah, thank you very much. Thanks for having me.
Okay, take care.
Okay,
Okay,
bye-bye.
bye.